Welcome to all of you to the annual Maternal Suicide in the U.S. webinar hosted by 2020 Mom. Today you'll get to learn about the latest research on maternal suicide and the latest efforts around data collection here in the United States. 2020 Mom is pleased to host this annual webinar with many of our partners who you'll hear from today. We'll move on to the next slide. My name is Joy Burkhardt. I'm the founder and executive director of 2020 Mom. You can learn a little bit more about me on our website at 2020mom.org, and we'll move to the next slide. I wanted to share just a little bit about 2020 Mom. Our mission is to close gaps in maternal mental health care. We just turned 11 years old this month, and at the core of all that we do is that we believe families, employers, and society, all of us who are paying for healthcare benefits here in the US, that the healthcare system should work to detect and treat maternal mental health disorders, and of course, in this case, also detect and treat maternal suicidality. Next slide. I have the great pleasure to introduce our speakers today, and I'll start with Susanna Trost from the CDC. Susanna's back with us for this annual webinar again this year. She is a CDC Foundation epidemiologist on the maternal mortality prevention team at the CDC's Division of Reproductive Health. She supports state and other jurisdictions' maternal mortality review committees, which you'll learn about today, in the identification of pregnancy-associated deaths, and contributes to the analysis and dissemination of data on pregnancy-related deaths here in the US. She holds an MPH, Master's of Public Health and Epidemiology from Emory University. We welcome you, Susanna, to the panel. And next, I'd like to introduce Dr. Lisa Klein. Dr. Klein is the program coordinator for maternal mortality review at the Delaware Child Death Review Commission. She has over 40 years of professional nursing, management, and research experience focused on the care of women and newborns. Her roles include serving in hospital settings and labor, delivery, mother-baby, and neonatal intensive care units, as well as pediatric units. She has also served as a nurse manager for an OBGYN clinic and also in other settings. She has served as a research investigator in genomic and microbiome research, and she received her Doctor of Nursing practice from Marymount University. Welcome, Dr. Klein. And our next slide will introduce Jamie Cabrera. Jamie is the Executive Director of the Colorado Perinatal Care Quality Collaborative, the CQC, or a PQC, you'll learn about in a moment during the webinar. The mission of her organization is to improve the health of pregnant and postpartum people, infants, and their families in Colorado. Jamie collaborates across sectors to influence clinical practice, public policy, and community supports that bolster the physical and mental health of individuals and their families. Jamie is driven to change the fact that the U.S. is one of the most dangerous nations to give birth. She has extensive experience in strategic planning, fundraising, operations, and finance. And we're also very lucky at 2020 Mom to have her as a board member. She earned her Master's of Public Health in Management and Policy from the University of California at Los Angeles. And Cindy Herrick, next, is the Partnerships and Special Projects Manager at 2020 Mom. After experiencing her own severe maternal mental health disorders in 2012, she became motivated to change the maternal mental health care system. She's also passionate about working to mainstream the discussion about maternal mental health in America. In addition to holding a Master's of Arts degree, Cindy became a certified mental health peer support specialist through a research project led by 2020 Mom. She's a subject matter expert in maternal mental health for Arizona's Department of Health Services Maternal Mortality Board, and she also serves on that department's Maternal Mental Health Task Force, where she chairs the Awareness Work Group. And finally, Cindy serves as a patient merit reviewer for the Patient-Centered Outcomes Research Institute, otherwise known as PCORI. Welcome to all of our panelists. Next slide, please. So I want to go over what we're covering in today's webinar. First, we'll provide a general overview of maternal mental health and maternal suicide statistics, rather, here in the US. We'll get an update on the latest data from the CDC on maternal mortality review, and also an overview of maternal mortality review committees and the latest report on maternal pregnancy-related suicide deaths and mental health deaths. We'll also talk a little bit about how states are improving suicide detection in their MMRC processes, including the role of key informant interviews in identifying maternal suicide deaths. We'll hear from Cindy on our team. We'll talk about 2020 Mom's latest issue brief or report, the executive summary released today on suicide tracking and prevention. And then we'll hear from Colorado on the latest report, MMRC report on including maternal suicide, that identifies maternal suicide as the top cause of maternal death in their state. And we'll talk about the role that PQCs, perinatal quality collaboratives, can play and should be playing in champion reduction of maternal suicide in their states. And then we'll wrap up with a Q&A, fireside chat around additional challenges and opportunities. Next slide. So we wanted to stop and make sure that everyone knows that this is a very difficult topic and that we have lost many mothers tragically to maternal suicide and overdose here in the United States. And we wanted to provide a trigger warning and confirm that this data is very hard to hear. And also wanted to just take one moment of silence to recognize and honor the mothers lost. And if you can join me in bowing your heads for just a few moments, that would be great. Thank you. With that, I'm very pleased to introduce our next speaker. Susanna Trost will be presenting her slides, pregnancy-related deaths, manner of death, suicide. So Susanna, I'll turn it over to you.
Thank you for having me today. My name is Susanna Trost, and I'm a CDC Foundation epidemiologist working on the maternal mortality prevention team in CDC's Division of Reproductive Health. I'll be presenting on pregnancy-related deaths with the manner of death of suicide to residents of 36 US states from 2017 to 2019. Next slide, please. I have no potential conflicts of interest to disclose, and the findings do not necessarily represent the official position of CDC or CDC Foundation. Next slide. At the national level, CDC measures maternal mortality data through two national surveillance systems: the National Vital Statistics System, or NVSS, and the Pregnancy Mortality Surveillance System, or PMSS. NVSS tracks maternal deaths, defined as the death of a person while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and the site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management, but not from accidental or incidental causes. NVSS uses death records to identify maternal deaths at the national level. The Pregnancy Mortality Surveillance System, or PMSS, tracks pregnancy-related deaths, which are similarly defined, but extend the time period for postpartum deaths out to 1 year after the end of pregnancy. PMSS asks states to send CDC death records that indicate pregnancy, as well as death records that have been linked with birth or fetal death records indicating a recent pregnancy. These records are then reviewed by CDC medical epidemiologists to both confirm pregnancy within the prior year and to determine whether the death was related to the pregnancy. Both of these data systems provide critical information on maternal mortality in the United States nationally. However, they both exclude deaths due to external causes of injury, including suicide. Next slide, please. State and local maternal mortality review committees, or MMRCs, have a critical role in maternal mortality surveillance. MMRCs are multidisciplinary committees that review deaths during pregnancy and within 1 year from the end of pregnancy. In contrast with NVSS and PMSS, MMRCs may identify and review deaths by suicide among pregnant and postpartum persons. MMRCs are uniquely positioned to conduct richer reviews that attempt to tell the full story of each person who died. They have access to a variety of information beyond just vital records, including social service, law enforcement, autopsy, prenatal care, and sometimes informant interviews. MMRCs are multidisciplinary, and the purpose is to understand the clinical and non-clinical contributing factors to pregnancy-related deaths to develop recommendations to prevent future deaths. Next slide. A crucial role of maternal mortality review committees is determining whether the death during pregnancy or within 1 year of the end of pregnancy was pregnancy-related. A pregnancy-related death is defined as the death of a person during pregnancy or within 1 year of the end of pregnancy from a pregnancy complication, a chain of events initiated by pregnancy, or the aggravation of an unrelated condition by the physiologic effects of pregnancy. Often, MMRCs ask themselves, had the individual not been pregnant, would they have died? Next slide. A recent analysis of MMRC data on pregnancy-related deaths among residents of 36 states found that mental health conditions were the most frequent underlying cause of death. In this analysis, pregnancy-related deaths due to mental health conditions were defined as any pregnancy-related death due to suicide, unintentional or unknown intent overdose or poisoning that was related to a substance use disorder, and other deaths determined by the MMRCs to be related to a mental health condition, including substance use disorder. Recognizing that mental health disorders, both acute and chronic, are a risk factor for suicide, and that the treatment of these disorders is an important prevention opportunity, CDC guidance is for MMRCs to classify all pregnancy-related suicides as mental health deaths. However, it is possible that suicides not related to mental health conditions were included in our analysis. Next slide. I'll now share some MMRC data on pregnancy-related deaths with the manner of death suicide to residents of 36 US states from 2017 to 2019. Next slide. Our analytic data set of pregnancy-related deaths from 2017 to 2019 includes data on residents of 36 states, shown here on this map. Each state may not have all 3 years of data, and partial years of data are included. Each state included is using the CDC Maria data system and has agreed to aggregate analysis. Next slide. MMRCs are asked to answer a variety of questions regarding the circumstances surrounding each death, including whether the death was a suicide, as well as the means of fatal injury. MMRCs utilize a variety of records, as well as the expertise of committee members to answer these questions. Potential sources include death records, autopsy reports, and police records. Increasingly, MMRCs also have access to informant interviews with next of kin or close contacts. A critical role of MMRCs is to determine whether each death is pregnancy-related. Based on CDC's pregnancy-related death criteria, colleagues in Utah published a standardized evaluation tool for determining the pregnancy-relatedness of accidental drug-related deaths and suicide deaths. Examples of the criteria are shown on this slide. This tool has been shared with jurisdictional partners through presentations and ongoing technical assistance by CDC's maternal mortality prevention team. Next slide. We received data on 1,018 pregnancy-related deaths from 2017 to 2019. Among these deaths, 971 pregnancy-related deaths had an MMRC determination for whether the death was a suicide. And 82 deaths, or about 8% of the pregnancy-related deaths with the determination, occurred by manner of death of suicide. The remaining slides will focus on these 82 deaths, referred to in subsequent slides as pregnancy-related suicide deaths for brevity. Next slide. 68% of the pregnancy-related suicide deaths occurred among non-Hispanic white persons, 20% among Hispanic persons, and 7% among non-Hispanic Black persons. The 0 deaths for non-Hispanic Asian and non-Hispanic Native Hawaiian and other Pacific Islander does not mean that there were no pregnancy-related suicide deaths among those groups during this time period, but that there were no deaths in the data used for this analysis. Next slide. And this slide shows the 5-year age breakdown of the pregnancy-related suicide deaths. Next slide. Based on the means of fatal injuries specified by the maternal mortality review committees, 43% of pregnancy-related suicide deaths were from hanging, strangulation, or suffocation. 28% of the deaths were due to firearm. 20% were intentional overdose or poisoning, and 10% were other means of fatal injury. Next slide. 80% of the pregnancy-related suicide deaths occurred more than 1 week after the end of pregnancy, with 66% occurring 43 days to 1 year after the end of pregnancy. 19% of the pregnancy-related suicide deaths occurred during pregnancy. Next slide. 99% of the 82 pregnancy-related suicide deaths were determined by the MMRC to be preventable. A death is considered preventable if the committee determines that there was at least some chance of the death being averted by one or more reasonable changes to patient, family, provider, facility, system, and/or community factors. While this finding on preventability is based on determinations made by the jurisdictional MMRCs, I do want to acknowledge that the mission of CDC's National Center for Injury Prevention and Control is no lives lost to suicide. Next slide. 66% of the pregnancy-related suicide deaths had at least one life stressor and/or substance use documented in the abstracted records. This information is based on both the completeness and availability of information to the abstractors, so it is important to note that just because a stressor was not documented does not mean it was not present in an individual's life. Similarly, the presence of a stressor in an individual's life does not mean that it necessarily contributed to the death. The most common stressor was history of substance use, which was documented for 35% of deaths, followed by history of psychiatric hospitalizations or treatment for 33% of deaths, and unemployment for 27% of deaths. 26% of deaths had documentation of a prior suicide attempt. The stressors shown here, such as childhood trauma, are risk factors for suicide in general, and so may not be specific to just pregnant or postpartum persons. Next slide. An important role of MMRCs is to make actionable recommendations to prevent similar deaths in the future. The next few slides include some recommendations made by the jurisdictional MMRCs for the pregnancy-related suicide deaths. These next few slides include recommendations for prevention made by the jurisdictional MMRCs, but this is only a subset of all recommendations made by the MMRCs for the pregnancy-related suicide deaths. No one strategy is likely to be sufficient to achieve prevention, and strategies for eliminating maternal mortality are diverse, multifactorial, and multi-level. Jurisdictional recommendations related to access to care include increasing coverage of extended psychiatric care during the postpartum period, increasing home visiting programs, developing committees to focus on expanding care to rural communities, system improvements needed to ensure additional pain management services, as well as culturally relevant interventions for traumatic birth experiences. Next slide. Jurisdictional MMRC recommendations related to coordination of care include increasing coordination with mental health and substance use providers, establishing processes for following up with patients who miss their appointments, coordinating care after fetal loss, especially when there's a history of fetal loss, developing relationships between healthcare systems and local intimate partner violence service programs to establish referrals and warm handoffs, and hospitals employing a social worker or case manager who can conduct and document needs assessments prior to delivery hospital discharge. Next slide. Example jurisdictional MMRC recommendations related to screening include making sure that providers, which would be inclusive of OBGYNs, pediatricians, and emergency departments, perform validated screening tools at prenatal and postpartum visits, making sure that providers document in medical records whether domestic violence was done and along with the results of that screening, universal integration of mental health condition screening and treatment into maternity care, as well as trauma-informed maternity care and screening for adverse childhood events. While these are recommendations from maternal mortality review committees, I do want to note that we don't have evidence about whether screening will reduce suicides, and as noted previously, no one prevention strategy is likely to be sufficient to achieve prevention. Next slide. Example jurisdictional MMRC recommendations related to education and training include WIC providing depression education material at their offices that are easily accessible to participants, facility development of discharge instructions that include signs and symptoms of postpartum depression, improving community awareness of signs of suicidal ideation, major depression, and postpartum depression, as well as awareness of resources for referral, making sure that obstetricians have training in mental health conditions in pregnancy, provider education on the importance of the postpartum visit and the implementation of postpartum depression screening, and increased awareness of perinatal mood disorders across all areas of medicine. Next slide. An example jurisdictional MMRC recommendations related to community resources include increasing availability of housing with priority for pregnant and postpartum women and women with children, exploring options to expand access to childcare during medical appointments, connecting individuals to other services, including transportation, healthcare, and substance use treatment, and making sure that programs include women with early pregnancy loss or fetal demises in the services generally reserved for pregnant or postpartum women. Next slide. And I'd like to end my presentation by sharing some resources. A technical package of policy programs and practices for preventing suicide is available on CDC's website. And I'm also including the numbers for the National Maternal Mental Health Hotline, as well as the 988 Suicide and Crisis Lifeline. Next slide. Thank you for having me today, and please reach out with any questions.
Thank you so much, Susanna, for your important share of the latest report and all of these findings, recommendations from the MMRCs that have participated in the Maria project. We're grateful for their expertise and their hard work in detecting maternal suicide so that we have a national data set on maternal suicide deaths here in the United States. Thank you again, and we'll be moving on to our next speaker. And I invite you all, if you have questions along the way here, you're welcome to drop those in the question box here in Zoom, and we'll get to those at the end of today's presentation. So next, I'm delighted to reintroduce you to Dr. Lisa Klein. We'll be talking about the suicide assessment work that her maternal mortality review committee has done in Delaware, including the use of key informant interviews and also adoption of some of the Utah criteria that you heard about just a moment ago from Susanna. So thank you so much. And Dr. Klein, over to you.
Thank you very much. I'm very, very honored to be here and speaking with such a wonderful group of panelists, but also to share with you all the importance of being able to consider suicide, even in a case where the medical examiner may not have labeled a case as a suicide death. And with the work that our committee has done, and gratefully with the work they did in Utah to be able to incorporate the Utah criteria, it has helped us in being able to both identify a case that is potentially a suicide, as well as determining whether the case was truly related to the pregnancy or simply coincidental in the year after the end of the pregnancy. Next slide, please. One of the things that's really important to understand with maternal mortality review is what it is and what it isn't. Maternal mortality review is an ongoing, anonymous, and confidential process of getting data, analyzing that data, interpreting that data, and identifying actions that may prevent a future similar death. It is a very systematic approach, and it is guided by policies, by statutes, and by rules. In Delaware, we function under a very specific state statute, and that statute tells us what we can and cannot do. For example, in Delaware, we are not allowed to review a death that occurred in the process of a crime. So, for example, in a domestic violence death, We are not allowed to review that case until the case is completely adjudicated or completely closed, and the person who was found guilty in the case, or not guilty as the case may be, is closed. However, in a case where, like one we had recently, where the unfortunately the assailant, the person who killed the woman, also killed himself, we were able to go ahead and review that case because it was considered closed. Another thing in Delaware that's different than in a lot of states is that we function under the courts. Many maternal mortality review committees function under public health, but we actually function under the courts, and as such, we are afforded the ability to subpoena records. Many cases in different states have to just request a record from hospitals and hope that they, and providers, doctors' offices, other agencies that may have had activity with this family, they have to request them, but we can actually subpoena them, which gives us the ability to get more records and be able to review them in a relatively timely manner. The maternal mortality review committees also are charged with the intention to move the data collection and the information that we have to prevention activities. And one of the ways that we are hoping to be able to do that, we have taken this information to a state commission, which has given the responsibility to different agencies in the state. But we are now, again, because of state legislation, going to be moving these activities, these recommendations to action through a community action team that is going to be reviewing all of the recommendations and findings, and hopefully have the authority to take these recommendations to actual actions and hopefully prevent deaths in the future. It is just as important to understand what maternal mortality review is not. First of all, we are not a process for assigning blame or responsibility for a death. We try to make sure that in the review of these cases that we are staying in our lane and only looking at what things might have been preventable in this case. This is not a research process. We are not trying to create new opportunities for people. This is not peer review. We are not looking at the providers and trying to identify things that they did correctly or did incorrectly. It is not an institutional review, so that we are not subject to an institutional review board, and we are not trying to review different hospitals, providers, etc. And it is not a substitute for the existing mortality and morbidity inquiries that are required to occur by institutions such as hospitals, substance abuse care providers, mental health providers, etc. Next slide, please. One of the things that we have learned in our process is about the intersectionality between substance use disorder and mental health conditions that have contributed to maternal mortality deaths. For example, this was in our review between 2018 and 2021, we had 22 cases where substance abuse probably contributed to the death. And we had 16 cases where mental health conditions were also contributing to the death. But in 15 of those 16 cases, we found that there was an overlap between substance use disorder and mental health. In 7 cases, we did have substance use disorder that was documented without a documented mental health issue. And in 1 case, we had a situation where a mental health condition was identified without substance use disorder also contributing to the death. But 15 cases had this co-occurring, where substance use disorder and the mental health condition both contributed to the case. Next slide, please. In my role, I am both the abstractor of the records that we get, and I'm also the one who creates the narratives, and I'm also the one who does an interview with a family member if we can find one who's willing to talk to us about the death. So what I do as the abstractor is I objectively look at clinical and social data on the birthing person who experienced a pregnancy-associated death. I know that Susanna talked about pregnancy-related deaths, and the report that she presented was on pregnancy-related deaths. Again, a pregnancy-related death is a death that probably would not have occurred if the woman had not been pregnant. A pregnancy-associated death is a death that occurs anytime during the pregnancy or up to 1 year after the end of the pregnancy, regardless of the cause and whether or not, if she had been pregnant, she would have died. So in Delaware, we review all pregnancy-associated deaths, and this might be a death from a motor vehicle accident. This might be a death from some kind of natural disaster, like a hurricane or something like that. We will review all of those deaths. Gratefully, in Delaware, we only have about 10 to 12 deaths per year. So we are afforded that opportunity to review all of the cases. But it does create the opportunity to say, was this pregnancy related or was it pregnancy associated? On rare occasions, we can't figure out whether it was actually related to the pregnancy or not. And we do have the option of saying that we do not know. When we review the cases, which can at times be as many as 4,000 to 5,000 pages of records on the patient, we then look at what are things in this person's history that contributed to the death. And through the CDC Maria guidance, the database that we use, racism, discrimination, and bias are things that we do consider in these deaths. And through doing these record reviews, I have been able to identify terminology that may identify racism or discrimination or bias, as well as statements from people and statements in the record that will suggest that it might have been possible that there was some chance that we could have prevented the death. But one of the most important, and I think one of the most challenging things that I do, is respectfully reach out to people who were significant in the life of the birthing person and request that they talk to me about the life of the person, about the pregnancy, and about what happened to them when they died, before they died, and throughout their life. I then take all of this information together and create a narrative, and I tell the story of this person who died, of the mother who died, and try and help the people who are going to be reviewing the case to determine what contributed to this death and what might have prevented the death. Next slide, please. One of the most helpful things that I have done recently in terms of my own professional education is participating in the National Fetal and Infant Mortality Review Storytelling Learning Collaborative. This was coordinated by National FEMR, and it was an amazing opportunity to work with experts to learn about, as they said, how stories can humanize and heal, deepen understanding and motivate action, and catalyze greater impact for systems change. In order to be able to do that, one of the things that I had to do was to consider my own anchor story. And I had to think about, what was it that convinced me to do what I'm doing today, to do what I did throughout my career, and try and learn more about me to help me do a better job of conveying the stories of the birthing persons that I am reviewing. And when I looked at my anchor story and thought about what were the things that happened in my life and in my career that guided me to what I am doing today, I thought about a story and a case and a family that I worked with relatively early in my career as an advanced practice nurse. And it was when I was working in vitro fertilization and reproductive endocrinology. And the story that I used was the story of the first family that we had who had an in vitro birth with us. And it was not only their first in vitro birth, it was also ours. We had just started doing this. And this family trusted us to walk this journey with them in trying to achieve a pregnancy. This was a young woman who had lost both of her fallopian tubes to ectopic pregnancies. So she was not going to be able to have a pregnancy in a natural manner. And so we supported them with an in vitro birth. And I think the most transformative thing for me in this case was having the opportunity to see the 8 cells under the microscope, and then 8.5 months later, hold that baby in my arms and know that that was the 8 cells that we had seen, and that we have moved so far in healthcare where we are able to actually help create life and see that life come to fruition and see that life grow and actually become a perfect human being. And because of having that in my heart, a lot of people thought about their anchor stories as kind of challenging things and sad things that happen in their lives. But to me, this helped me move forward in seeing how lives can be affected by difficult things that happen in their life and how they can move forward into positive things. Doing mortality review is a very challenging thing to do. It's sad. It makes us think about, what are the worst case scenarios of things that can happen. But we also have to be able to move forward by looking at positive things. And I think that in maternal mortality review, looking at the positive things is one of the things that helps us move forward and be able to identify ways that we can prevent these deaths in the future. Next slide, please. In telling these stories, we have to honor the lived experiences as part of the death that we're looking at. If we don't know the whole story, and a lot of these stories are tragic, they're very, very sad. A lot of these birthing persons had trauma through their entire lives, and their death was just the final trauma that happened to them. And the suicide, if it is a suicide death, can be, to me, one of the most tragic traumas that they can have. But if we don't know the whole story, if we don't know everything that fed into this woman's life, we're drawing conclusions and making recommendations based on limited information. If I can get an interview, it is the closest we can get to the voice of the individual who died, or the voice of the family who experienced the loss. I can't get an interview in every case, but every time we get an interview, our stories are more enriched, and we are able to, I think, make better recommendations and suggestions on ways to prevent these deaths in the future. Next slide, please. I want to tell you a couple stories that we have learned and that helped us, how the interview helped us to be able to figure out, was this a suicide or was this simply a tragic death that occurred? And I always use pseudonyms when I tell my stories. I think that having a pseudonym in the narrative helps to make this more of a person, not just a decedent, not just somebody who died, but I think that it helps the team as we are reviewing the case to think about the person that is associated with the death. And Crystal was a young woman who died just about a year after giving birth. And she unfortunately crashed her car into a light post and had a traumatic head injury that was not going to be able to be reversed. It was learned when they did a drug screen on her, as is common with anybody who has a single car accident, that she had ingested cocaine that had also had fentanyl with it. It was known from the medical records that I reviewed that she had a history of depression and anxiety, and her mother kindly agreed to talk to me and share with me that she was worried when she had the accident that Crystal may have been suicidal. But shortly after Crystal died, she found a diary. And Crystal's diary talked about all the hopes and visions that she had for herself and for her baby. Even though she was no longer involved with the baby's dad, she really talked about going to school and things that she wanted to do. And so with that information, Crystal's mom was able to tell me that she felt confident that this was not a suicide, that she felt very confident that this was simply an accident that happened after Crystal had unfortunately gone back to using some drugs that her mom thought that she was finally off of. The diary also talked about Crystal's struggle with her anxiety and her depression, and how she felt she had difficulty connecting with her therapist because she was only able to meet with her therapist through telehealth because of COVID. And this helped us also look at this death in terms of its relation to COVID. We would not have known that there may have been a relationship with this death and possibly her return to drugs because of her inability to feel connected to her therapy with the telehealth that was required due to COVID. Next slide, please. Another case we looked at was a young woman who died very early in her pregnancy. She was only 12 weeks pregnant, and she had initiated prenatal care about a week before she died. She was living with a much older relative. Molly was in her early 20s, but she was living with a much older relative who was the person who found her after she died. She had a known history of substance use disorder, but we could not find any record of mental health history, only the substance use disorder. And the relative with whom she used agreed to talk to me. And this relative shared with me that this death that had been classified an accidental overdose by the medical examiner, that Molly had scheduled an abortion for the week after her death. But it was unclear from the information we had whether the pregnancy was an undesired pregnancy or whether Molly was not able to manage the challenges that she was facing because of the pregnancy. The relative told me that the boyfriend had just told Molly that he did not want to get married and he did not want to have the baby, and that if she had the baby, she was on her own. And at 87 years old, the relative had also told Molly that she could not live there if she had the baby. She was going to have to find other housing because he could not manage having a baby in the house with him. The relative reported that the morning when he found Molly, her entire living space was spotless. It was totally cleaned up. Her bathroom was clean. Everything was put away. Her room was cleaned. It was vacuumed. And this was not like her. This was not her usual space. Usually her space was pretty messy. And the relative felt that Molly had cleaned up the space so that he would not find it all messy the following morning when he found her, and he would not have to do it. And based on the information that the relative gave us, even though the medical examiner classified it as an accidental death, we disagreed with the medical examiner. And as a team, we felt that the death was actually a suicide. This is how the interview can help change the perspective on the case and change what the reviewers think, and help us then in terms of being able to make recommendations on preventable deaths that can occur after a pregnancy or during a pregnancy. I thank you all very much, and I look forward to hearing your thoughts and your ideas when we do the fireside chat. Thank you.
Thank you so much, Dr. Klein, for your incredible work and also pointing out the importance of understanding a person's lived experience and story, and the importance of key informant interviews and getting this right, these designations of maternal suicide. I next have the great pleasure of turning it over to my colleague, Jamie Cabrera, who's going to be talking about the work that Colorado is doing starting to look at preventing maternal suicide. We're going to be talking about the role of perinatal quality collaboratives in particular, which are separate from maternal mortality review committees, but take into account the recommendations from MMRCs. So with that, Jamie, I'm really grateful you're here and glad to turn it over to you.
Thanks, Joy. Thank you for having me. Yes, I'm really excited to dive into some of the practical solutions that we are working toward in Colorado to address this very critical need. And so we'll go ahead and dive in. Next slide. Just a brief overview of what I'll cover. I will share some context in the data and what we know in Colorado. A lot of it mimics some of the information that you've seen what's happening nationally. And so we'll go through that fairly quickly, but I think it's important to share the context of what we know and how that lends to the PQC's role and the implementation of some of the interventions that we're currently working on. We'll talk a little bit more specifically about those clinical quality improvement resources and projects that are in flight in Colorado, and then we will discuss how we've really moved from hospital improvement work to integrating healthcare delivery systems and community supports. Next slide. So as mentioned, I will cover our Colorado Department of Public Health and Environment data. The data period that I'll share today is 2014 through 2016. We are currently reviewing more recent years, and we'll have a published report come out in the very near future. And I must say, as part of our work as a perinatal quality collaborative in Colorado, we are actually written into legislation as the implementation arm of the MMRC. So the recommendations that you saw at a national level, we have those here locally in Colorado, and CPCQC is charged with implementing interventions to address those recommendations. Next slide. One thing that I do want to call out, you've heard a lot of this throughout the other speakers' conversations today. We in Colorado, through our Department of Public Health and Environment, recognize the lack of community voice that was at the table. And recently, in the past year, conducted a targeted outreach and invited participants to join the MMRC. And that resulted in the onboarding of 19 new members, 10 of which identify with marginalized community. And it has certainly brought discussion and rich understanding about the variation in care that we see by geographical community, race, ethnicity, individuals that identify as a different sex, and it's been very robust in helping us to fully dive into these experiences and better understand the communities that we intend to serve through this work. Next slide. This is just a link. I see someone just popped that in. So if you're interested, it is published, was published in July 2020. You can go there for more information. Next slide. Just a quick overview of 94 deaths during this period. You can see that our death-birth ratio has been fluctuating, but certainly increasing as we're seeing nationally. So much work to do. Next slide. Our number one cause of maternal death in the perinatal period, pregnancy and postpartum period, is suicide. You can see, followed very closely by drug overdose. And as you heard mentioned today, a lot of comorbidities exist. So we have to take that into consideration. And then when we look at our homicide, which comes in the top 4, when we dig into that data, we see a lot of intimate partner violence homicide as a result of that. So certainly considering the things that you've heard others mention as well in our priorities in our work. Next slide. Just to give you a little bit more context here, this is by age. I'll run through these fairly quickly. Next slide. Certainly variation in outcomes by education. Next slide. By region, as I mentioned, rural and urban. Next slide. Type of insurance. So this is something we dive into deeply in our work, is our state Medicaid coverage versus other. Next slide. Race, ethnicity. We could spend hours on this, but we'll just, for today's purposes, share that with you briefly. Great disparities there in some of our race, ethnicity data that we see in outcomes. Next slide. And we look at the time period in which death occurs. And as you can see, up to 6 weeks postpartum has the highest rate there. So certainly looking at what's happening during pregnancy, in the prenatal period, and then postpartum. Next slide. As you heard mentioned nationally, similarly in Colorado, nearly 80% of our deaths are deemed preventable. So a lot of work to be done. Next. and the most frequent contributing factors for suicide deaths. So we dive into that, and this is where we hone in and make recommendations as an MMRC. I have the privilege of sitting on that committee and then working on the recommendations and then how we'll actually implement that as the leader of our state's PQC. So you can see poor continuity of care coordination. So those fragments that we see across facilities, within the same facility, we often see a lot of our individuals show up at the emergency department, and there's a big gap there between follow-up care and what's happening in outpatient practices or even community supports. We recognize that unhealthy social support from families, partners, and friends or non-existent is a big gap here for us. And then factors that place the person at risk for poor outcomes were not recognized or acted upon. So we do talk about that in terms of conversational screening, and you'll hear more. Next slide. We do supplement our data from our MMRC with some of our other data sources across the state, and some of those very much have qualitative data from those with lived experience, identifying as pregnant or postpartum in a longitudinal study called Healthy Moms. And so I'll briefly cover this. Interactions with healthcare workers certainly leave a lot to be desired when we're hitting that, approximately 50%. We have a lot of work we can do there to implement positive interactions, and people not talking about resources specifically for anxiety and depression. So again, sitting at about 52%, and then 18% reporting that any of the resources listed they had never heard of, or they were never discussed with them by a healthcare provider. Next slide. Barriers to access, we see these across the nation and many other states as well, but you can see here are concerns of cost, childcare, not comfortable having conversations, not able to take time off work or get an appointment, and certainly concerned about somebody finding out that they have a mental health issue or condition, which has a bias, certainly, and a stigma around it. Next slide. So how do we address stigma? When we look at this, we have to understand where stigma occurs and why people feel that it exists. And then we can talk about how we educate our healthcare staff, providers, and communities to better support this. So as we see conversations aren't taking place, people feel embarrassed or judged. And there's a big one where people feel that their parenting will be questioned. And so folks are really concerned about admitting or saying that they have anxiety or depression or suicidal ideation throughout their pregnancy, and fear of losing their children and having the system called, and people then work through that in what could be perceived as a negative way instead of positive supports and resources for that individual. Next slide. So our MMRC, like the CDC at the national level, takes into account all of the information that we have available when we review our cases. We look at discrimination, resources, lack of, obviously, and other things that come into play, and how we can prevent these deaths. And then we write recommendations. So these are the recommendations from the report period I'm sharing. You can see here screening, certainly, education, care coordination, access to preconception, pregnancy, postpartum supports, standardized care, and a number of other things, and that we'll focus on how we're actually addressing these recommendations in Colorado next. All right, so let's dive into what I think is the fun stuff. This is the world that we as a PQC live in, is clinical quality improvement. Next slide. So we focus on a number of strategies and activities to actually address what we see as the gaps. A number of those are training and education learning sessions. We build our work around the Institute for Healthcare Improvement's Breakthrough Series model, where we form a learning collaborative. It's a multidisciplinary team. It involves hospital partners, outpatient partners, community-based organizations, and we bring those individuals together. Our biggest focus over the past few years is also bringing in those with lived experience. So really focusing on patient-provider partnership of care in all the work that we do. So we bring the multidisciplinary team together, and we provide education topics, and then we have open discussion about where folks are having challenges or barriers, or where they might be having success, where they can share that with others. So we start by education, certainly focusing on better identifying, understanding perinatal suicide. We partner with March of Dimes to implement bias in maternity care training, and that can be bias for substance use or geographically where the individual lives, a number of biases that we know are inherent sometimes in the work. And so we focus on education and tools to help address bias. We look at the importance of social determinants of health and really wraparound services where individuals who might not have food or housing or have other insecurities and aren't able to actually get what they need to then show up for a prenatal visit or have supports that are really critical during that perinatal period. We focus on chronic stress that really ultimately leads to behavioral health needs. And those come out in, as you've heard mentioned today, substance use, anxiety, depression, suicidal ideation, and a number of other things. And we also really focus on educating our providers about trauma-informed care. Coupled with that, we look at data collection, analysis, and reporting. So we do rapid cycle feedback, improvement cycles with our hospitals and their partners in the outpatient and community setting to actually say, let's introduce conversational screening in your setting. What does that look like? How can you share more information with your patients and every patient, ensure that they have the resources that are needing? And then we look at the data improvement over time so that they can actually see if improvements are made and progress is happening, or where they might need to make adjustments. So it's true quality improvement where we're always learning and we're not punitive in what we're seeing. And then, like I mentioned, we really bring in that partnership of care with our patients through our Family Integration to Restore Trust program, where we actually stipend them for their participation in any level of the project work or the organization and ensure that they have supports necessary to participate like every other expert that we bring to the table in the Perinatal Quality Collaborative. The importance of bringing together providers and patients as partners in care, and certainly the multidisciplinary care team that we heard mentioned throughout today's excellent talks is really integrating non-traditional care team members like doulas, peer support specialists, support groups in the community, and certainly, as others have mentioned, OB, neonatology, pediatrics, and really thinking about the maternal infant dyad of care and how we treat the family and provide supports for the family as a whole unit. And then a lot of our work is also entering into advocate for policy change. So I'll briefly touch on a couple of those as we make our way to the next slides. So to provide some resources, I saw that coming through chat, where we started as the Colorado Perinatal Care Quality Collaborative was as a member of the Alliance for Innovation on Maternal Health program, or AIM program. We had access to what they call patient safety bundles. And the bundles are a very nice comprehensive toolkit that really focus on what you're seeing here, the 5 R's, they call them. And so it basically walks the hospital or outpatient practice or the entity that we're working with through a series of kind of checklists or recommendations for standard protocols. And this is grouped together by clinical topic. And so at the time when we kicked off our first learning collaborative, there was not a perinatal mental health patient safety bundle. So you can see that's currently in development. So we're really eager to have that in the coming months to use as an additional resource. But what we did was take the opioid use disorder patient safety bundle, and we modified that for all substances because we knew that substance use was one of the top killers of pregnant and postpartum individuals in our state. And we knew that comorbidities existed. So we leveraged a lot of those tools and information to really focus on protocols with our hospitals and our outpatient practices to implement universal comprehensive conversational screening just to really better identify needs of patients, but really focused on our community connections and resource mapping. So did hospitals know what resources exist in their local counties or communities or regions to make referrals to when needed for specific mental health conditions, and specifically suicide being one of those? And did they know where community-based supports like focus groups or peer supports actually were housed such that they could make referrals to to those types of supports as well. And so we leveraged that patient safety bundle as our starting point and our primary intervention to really walk our hospitals through readiness, recognition, providing those education learning sessions, like I mentioned, helping with data support, analysis, and reports back to them, and then really trying to focus on that patient-provider partnership of care, which is respectful, equitable, and supportive care. So this is a great resource. We can ensure that everybody has that. And as you see here, the perinatal mental health conditions, that specific bundle is in progress. So we'll share that when it's ready. Next slide. Another great resource, and I am a little biased, so I'll call that out transparently. I'm a 2020 Mom board member and am passionate about this work. And the 2020 Mom organization has done a phenomenal job at creating the Hospital Whole Mom Survey. And so when you look through this, you'll find a lot of similarities with the patient safety bundles and the zero suicide framework. I saw that come up in chat. So there's a lot of resource and toolkits and information that's out there. So it's really about finding what works best for your organization, whether you're a hospital, an outpatient practice, or a community-based organization that is really focusing on suicide prevention and what you can do about it. All of these tools will walk you through training opportunities, protocols. The Whole Mom Survey is great. It asks questions about what you might already have in place and things you might be able to implement to really be able to provide the best, most comprehensive wraparound services for the patients that you're caring for. So this is a great resource, and we'll make sure you all get that in the chat too. Next slide. And then just to wrap up, what we quickly recognized, a true perinatal quality collaborative, our focus was always in the hospital setting. And we quickly recognized that in order to really make change, we had to get upstream. We couldn't just focus on hospital care, which is limited to a number of hours or days, that we had to partner with those who are providing prenatal care, those that are seeing individuals in that prenatal period in whatever way they're supporting them, and then certainly getting downstream. As you could see in our data, a lot of deaths are occurring in that postpartum period. So we focused on the expansion of our role to facilitate and convene healthcare delivery systems, being hospital-based and outpatient, with a number of partners that were already doing that work with our community-based supports, and some of those community-based organizations providing peer support, doulas, parenting classes, a number of other things that are available but not yet connected. Next slide. And so this is what we're really focused on right now in Colorado is, again, that integration through a program that we've been piloting for the past year called Impact BH, or Improved Perinatal Access, Coordination, and Treatment for Behavioral Health. We are focused, again, hospital, outpatient, and community. So based on the different entity and their process, screening might look different. What they're screening for, or how they're screening, and when they're screening. So that varies based on the individual organization's needs and patient population and timing of care. And then certainly focusing on that referral to appropriate community or specialty care with documented follow-up. So not just saying, well, we said you can call this entity and hope they get an appointment, but did they get an appointment? Did they not? Were they seen? How can we better support that continuum of care? And then ultimately increasing utilization of all these different types of services, and ensuring that through workforce and additional training, there are actually people available to treat the individual when we identify a specific need. And then working through ultimately improving the interactions and relationships among the care teams and the perinatal individuals and their families. So this is our focus, and really quickly recognize there are a lot of tools and resources. You have to pick the ones that work best for you and your organization, and that our role as a PQC certainly broadened from in-hospital, really focused interventions to integration of healthcare delivery and community supports is where we really believe that we'll see the best results. Next slide. All right, and I know we're gonna flip it back, Joy, for our next topic and discussion. So with that, I will hand it back to you.
Thank you so much, Jamie. Really helpful to, thank you so much, Jamie. It's really helpful to hear about your important work in the Perinatal Quality Committee in Colorado. And also good to understand the connection to the AIM bundles and the forthcoming revision to the maternal mental health AIM bundle. We're going to flip to the next slide, and we get to hear now from one of our staff members, Cindy Herrick, who will be turning on her camera here and talking a little bit about the report that will be issued next month, and introducing the executive summary, which you can see a snapshot here on the screen. So Cindy, I'm hoping you can turn on your camera and we'll turn it over to you.
Can you see me, Joy?
We can see you. Yes, very good. Thank you, Cindy.
Okay. Great. Thank you so much, Joy. So as Joy said, I'm very excited to talk about 2020 Mom's forthcoming maternal suicide report, which includes today's advanced release of the report's executive summary. Someone's dropping the link into the brief, to the executive summary of the brief in the chat right now. Some things that are going to be covered in this executive summary include risk factors for maternal suicide, which include mental health factors and environmental factors, which include pre-existing mental health conditions and a history of abuse, which Susanna had earlier talked about and Lisa had touched upon when talking about trauma. And I also wanted to highlight that in the actual report, not so much in the executive summary, we look at the spectrum of suicidal ideations, as well as delineating ideation from intrusive thoughts that are very frequently experienced by moms during the perinatal and postpartum period. And sometimes these thoughts can include intrusive thoughts about suicide. So that is in the upcoming report, and we're going to discuss that in there. We also talk about the risk for maternal suicidality as delineated via race, as well as both pregnancy-associated and pregnancy-related deaths due to a mental health condition. And we also are going to talk about maternal suicide prevention strategies and programs. We've had a lot of questions about prevention today that I saw. And I want to say that while we recognize that suicide prevention requires an entire framework of interdisciplinary change, we're also making recommendations both in the executive summary and in the actual report based on individual evidence-based interventions and screenings and treatment methods, because we recognize that not every healthcare system and model may have either the need, resources, or capacity to adopt an entire framework. So individual aspects of that include screening for maternal suicidality, in which we highlight the Columbia Suicide Severity Rating Scale, also known as the CSSRS, and the safety screener, as well as the ASK tool, which are all evidence-based suicide screening and risk assessment tools that should be used to assess for suicide risk in the perinatal and postpartum period by frontline providers like OBGYNs and also in emergency rooms. We also have a section that talks about effective treatment for suicide and how effective treatment must target directly suicidal ideations and behaviors through evidence-based models of treatment, which also include CBT, cognitive behavioral therapy specific for suicide prevention, dialectic behavioral therapy, DBT, and the CAMS model, which is collaborative assessment and management of suicidality. And a lot of these things fall under the Zero Suicide Framework, which includes 7 aspects to it, which we kind of touch upon in the executive summary. And it is a very, it's a great framework and considered the gold standard right now in suicide prevention work in the United States. And within that, we also talk about the least restrictive model, which includes the creation of safety plans, because research suggests that treatment should be carried out in the least restrictive setting possible for patients. And this is a new paradigm for a lot of healthcare providers, as most tend to refer to ER for assessment and treatment and, hospitalization. And so we talk a little bit about the best practices of addressing that. So the link has been dropped in the chat. And so take a look at that today, and the full report will be out in October. I'll turn it back to you now, Joy.
Great. Thank you so much, Cindy. I'm really excited about the report and want to thank you personally for this incredible work. We're going to ask our speakers to now turn on their cameras and join us for the fireside chat component of today's session. So speakers, if you could join me back on the stage here. I want to start by asking and inviting Cindy to answer a question that I would love to tease out for our audience. You talked a little bit about suicide prevention and treatment, and I thought it'd be helpful to spend a moment on some of what you tease out in this critical report on maternal suicide, and that we're really not just talking about treating depression and anxiety, which is what we all typically think about doing. And you did just touch on some of the treatment modalities that are used to prevent and treat suicidality. But can you just help us distinguish between the two? It's not that we're saying don't screen for depression and anxiety. It's just that you have to do more.
Absolutely. And I kind of glazed over it in the interest of time when I was talking about the Zero Suicide Framework, which is actually very intensive. It's made up of 7 elements, which is lead, train, identify, engage, treat, transition, and improve. And within that, we have identify, which includes screening and being trained to screen, and also treatment, which is what we were talking about with the evidence-based interventions, which was the different modalities. I listed 3, which was CBT, DBT, and CAMS. And the latest research, shows us that these treatments have to be specifically tailored for suicide prevention. Historically, a lot of clinicians have sought to treat patients with suicidal behavior by solely treating their mental health problems, which, as you said, can be depression, anxiety, any of that, which is often very, comorbid, intricately related to suicidal ideation, suicidal behavior, suicidal risk. But what we're teasing out now isn't, we're not telling people not to treat mental health problems, but we're saying that there is training and specific interventions that are developed specifically for suicide prevention. And so the CBT, for example, is a method of treatment that we use for a lot of mental health issues, but there is CBT therapy specifically for suicide prevention, so CBD-SP. And the other issue of that is that follows under treatment is the least restrictive model of care, which they call the stepped care model. I think there might be, a lot of people may jump from, there's suicidal risk, hospitalization. Under this model, you step up to avoid hospitalization as much as possible. Now, obviously, this takes a lot of, I think the big punchline is that it takes a lot of training and people who know what they're doing to make that safety assessment and that safety plan, and to be able to do outpatient interventions safely. And so that part, I think, is new to a lot of people, but has been standardized, I believe, in the suicide prevention world for a bit now.
Thank you, Cindy. I think it's going to be a really great call out. This brief is coming out in a week or 2, so be on the lookout for more detail. The executive summary is available now as a teaser, but something that the field surely should not miss. And one final point that I think the brief or the report does a really good job at teasing out is that a thought about suicide does not necessarily equate to suicide risk, and something that our field, I think, has not done a good job with, and we've caused harm perhaps to mothers by quickly referring to the ER, who may hold mom against her will, still not release her with a treatment plan, and cause more trauma. So some really incredible information in this forthcoming report. So Cindy, thank you again for highlighting some of the really key points, critical points for the field. I'd like to open it up to others on the panel to address some of the questions that came up in the first half of today's session. And I wanted to start with a question. I think this will be geared towards Dr. Klein and Susanna, to learn more about potential additional cuts of data that may be forthcoming. For example, we heard Jamie, and I think also you, Dr. Klein, just mention both access to reproductive care, family planning, and whether there might be trends around increased rates of suicide for patients and mothers who don't have access to family planning or reproductive care and birth control, for example. And also, if you could touch on whether we might have data soon about, we know there's disparities around race and ethnicity that are critically important to lift up. We're wondering if there's trends to share yet on gender identity. So patients who don't identify as male or female or transgender or non-binary, for example. So I'll turn it back to, I think, to you to start, Susanna, to share what you may be aware of, and then Dr. Klein.
Sure. Thanks, Joy. And thanks for those questions. So I think an important piece of the data that I didn't incorporate into the presentation today is really the contributing factors that get captured by the committees. And so for every death that a committee reviews and determines to be preventable, one of their main roles is identifying contributing factors to those deaths. And within those contributing factors, they provide a description, a detailed description of exactly what happened and how that factor contributed to the death, as well as that linked recommendation in order to address that factor and prevent the death. So I did share some of the recommendations, but I didn't share the contributing factors. And I think we do have a lot of work to do on our team to be incorporating some qualitative analysis to really be understanding those contributing factors to the death. And I know Jamie also shared some of the contributing factors that were documented by Colorado's committee, but I do think that's a big piece and a big role of the maternal mortality review committees, and definitely something that does get captured for every preventable death that they are reviewing. And then to answer the second piece around the gender identity, a pregnancy-associated death, which would be the deaths during pregnancy or within a year of the end of pregnancy that get reviewed by the committees, that would be any death that occurs during pregnancy or within a year of the end of pregnancy, regardless of that gender identity. So if a jurisdiction does identify a pregnancy-associated death, they are encouraged to review that death regardless of the gender identity. And we are also collecting information on gender identity within our standardized data system for the abstractors to enter that information when they're abstracting each death.
Helpful. Thank you so much, Susanna. Dr. Klein, anything you want to add?
Just as Susanna said, the addition of the information on gender identity is very new to the database that we use. So we're just now beginning to have a place to include it. However, I can tell you that information about access to reproductive care there's not a good place to document that in Maria. It's interesting because in the world that I live in, I also work with our fetal and infant mortality review, and I do the interviews for that process as well. And there are specific questions that are asked about if they were given any type of birth control or any type of reproductive planning that was discussed with them at the time of discharge, if they had a delivery, or if they had an elective termination, if there was any discussion of that. There's not a good place to document that. I'll include that in the notes about a visit. If there was a provider visit, I will include that. And in the database that we have in Delaware, where we take the information from the national database, but we also have information that we're also looking for. And we actually do collect that data on, was there reproductive planning discussed with the woman? Did she have access to it? Should she have any problem obtaining it? And that's one of the things we look at.
Thank you for sharing that information, Dr. Klein. Appreciate it. I want to turn now to Jamie, something that you hit on, and of course the maternal mental health field knows that stigma is still alive and well, and that one of the efforts that the field has been working on is universal screening by obstetricians now and other providers, right, using this sort of no wrong door approach, or icing on the cake approach, as we say. But yet we know that screening for maternal mental health disorders aren't yet routine, even though trade associations, professional associations like the American College of Obstetrics and Gynecology and others do recommend screening. So there's work to be done on that front. I want to acknowledge that first and foremost, but also wanted to get the panel's thoughts on the issue of, Jamie, you hinted at this from my perspective, but this nature of patients feeling concerned about raising maternal mental health disorders on their own if a provider isn't screening, or even if they are screening and using the wrong language and they just don't feel safe. They have this fear of babies being taken away, or child protective services, being called. And of course, we hear about these tragic stories often. One of the things we have learned about at 2020 Mom, and I'm curious about our panelists' perspectives about this, is that in the substance use disorder space, plans of safe care, through federal regulatory legislative framework, are in place to ensure that babies can stay at home with mother with these plans of safe care in place. I'm just curious if in Delaware or Colorado, if you know if something like that's been thought about for maternal mental health, and or if you're seeing that those plans of safe care are really working around substance use disorder for mothers. Any thoughts on that point? Susanna, please also jump in. And Jamie and Dr. Klein, don't mean to put you on the spot here. If you know of anything happening, please share. And if not, we'll be digging into this topic later and we'll bring people back to discuss it once we have more information.
I can tell you that in Delaware, we've actually talked about the fact that the moms who have a substance use disorder, we do complete, there are plans of safe care that are established and for the families, but we've talked about in our meetings in terms of our recommendations that it does need to be expanded, that we have to look at the vulnerability of the person who has had the baby and or is having the baby and identify ways that we can try and address those vulnerabilities, whether it be substance use disorder, whether it be mental health, whether it be trauma in the family, even domestic violence. And when we see the challenges with domestic violence, we even talk about the fact that so many times we'll find that they were screened, but they denied it. Mm-hmm. The screening for suicidality is something that we'll often find, but that's the screening for simple mental health concerns is not incorporated well into every admission history that nurses are asked to complete when a patient comes into the hospital. And we need to improve that. And I'm hoping the new guidelines that have just come out from the Preventive Services Task Force about screening for depression and anxiety, and particularly anxiety, which is such a big issue with birthing persons. I'm hoping that that's going to change the way that screenings are occurring in hospitals and in doctors' offices as people present for care.
Great, thank you. Jamie, anything you want to add? And we can touch on the anxiety recommendation here when you're done, Jamie.
Yeah, so many thoughts and agree. And I think the PQC, we live in the world of reducing variation in care. And I think that's the heart of a lot of the problems that we're seeing and why there are gaps is, for example, plans of safe care in Colorado very much focused on substance use, and there's been a lot of work and a lot of conversation around it. And then we find that hospitals have different internal protocols in terms of toxicology screening and when it's required and when it's not, and transfer and so it gets really complex because there's such variation, and it takes time to change that variation and to create standards and to implement them. So I think you're absolutely right. Like Lisa mentioned, really focusing more broadly, like we've been trying to really focus on chronic stress, and that comes in many different forms based on a number of things that ultimately then result in anxiety, depression, suicide, a number of other outcomes, poor outcomes. And so I think we try to really focus on conversational screening in a way to get to the heart of like what actual tool or resource should I then use to identify a particular medical need or behavioral health need or mental health need. And I think providers in our experience get overwhelmed. I can't administer 10 screening tools. So how do I have a conversation to help identify what might be an issue and then pick the right screening tool and know when to refer and have referral resources already identified so that if it is something beyond what they can treat, obviously as an OB or a pediatrician, how they have a referral source, they can dial a psych, right? We always talk about that, but that works when a provider can get support from another specialty provider, providing them with education to better identify suicidal ideation or things that aren't, common in their practice. And so I think there's so many interventions that need to happen, and that's where it gets a little complex. But we have to reduce that variation in care because each provider, each hospital, outpatient clinics, and so on down the line is doing things differently. So the things that we talked about today, the tools, the resources to implement best practices and have that standard of care that's every patient, every time, that gets to the heart of what the actual needs of that individual are. And then they have the right referrals to make to get the patient either a brief intervention or referral to the right type of treatment that they need is so important. So we see plans of safe care as designed for substance use in Colorado definitely is working, but across the board, there's definitely some work to be done to actually standardize that and ensure that every hospital and outpatient practice and those implementing it are actually have the same protocols in place to support it. So that takes time to get there.
Excellent. Thank you so much. And
if I could just add one thing, Joy, I think it's really important to stress the collaboration between the perinatal quality collaboratives and fatality review committees. We don't want them. We don't want them to get to us. We need the standardization to occur before they get to a point. They have to be screened for anxiety. They have to be screened for depression. They have to be screened for adverse childhood events, because those are the things, those are the stresses that pile up and lead a birthing person to die. So without that collaboration, we're not going to get to the bottom of it.
Great. We are out of time, and I love that point from you, Dr. Klein. I want to pop up for our remaining attendees a poll that we invite you to take. It's just a simple question, whether you found today's session to be helpful. And then as we're popping up that poll, I'm hoping our team can pop that up now. As we're popping up that poll, I would like to invite Susanna and Cindy and Jamie, if you have any other final thoughts. Dr. Klein, I heard you say collaboration is key between PQCs and MMRCs, and I think providers you alluded to as well. So I'm going to invite Susanna, any closing words of wisdom for you that you want to impart to our audience today around maternal suicide?
I just want to say thanks for letting us join the presentation today and sharing this data, and especially thanks to Lisa and Jamie and all of the jurisdictional maternal mortality review committees who are really doing all the work to collect this data, review these deaths, so that we can share the data. So thank you.
Very good, Jamie.
Thanks, I agree. Thank you for allowing me to be part of this. And I just love that we're raising awareness and we together can reduce the stigma and all that occurs and continue to address the needs of individuals pregnant and postpartum. It's so critical. So thanks for allowing me to be here.
Thank you, Jamie. Cindy, any final words of wisdom or imparting advice for our listeners today?
I am just very excited about the integration of suicide prevention work into the maternal mental health care and maternal health care system in general, and just this opportunity and the people who have attended to kind of spread awareness about this forthcoming report and all the great information in it.
Very good. And I just want to thank our partners, in addition to the CDC and our MMRC and PQC partners, thank the American Foundation for Suicide Prevention, the Zero Suicide organization and network, and also American College of Obstetrics and Gynecology and other partners joining us today. Thank you so much. Let's stay connected. You are welcome to continue to email questions at info@2020mom.org, and more to come on this important dialogue around preventing and tracking maternal suicide in the US. Thank you all.